Okay, so this is anytime you feel my sound isn't so clear, the slides are not clear, please give me a notification about that. طيب, this is a continuation of the previous lecture about pericardial disease. Last time we have discussed pericarditis and pericardial effusion and the tamponade. Today we are going to discuss constriction and some other few topics pertinent to the pericardial disease. Now, for pericardial cyst, what does it mean? Now, where is the pericardial cyst in this chest X-ray? It's the one on the right, which is this one. So, what is the typical location of pericardial cyst? What's the typical location? Typical location is the right cardiophrenic angle, which is this one. It can be found anywhere, but the most common location is the right cardiophrenic angle, okay? Sometimes it can be raised hemidiaphragm or hiatus hernia differential diagnosis, remember that? But it has typical location and typical appearance like this. This is also pericardial cyst in AP view and in the lateral view. Pericardial cyst, and this is pericardial cyst in the cardiac CT. You see, filled with fluid. So, in echo, the right cardiophrenic is here because the diaphragm is here. So it is cardiophrenic angle, which is here. So you are gonna find it in close proximity to the right atrium, okay? And usually detected in the subcostal view, okay? And you need to decrease the depth شوية, لأنه if you use the conventional depth of echo, you might miss it, you know? So you need to zoom out and to increase the depth to see around the heart. So this is a pericardial cyst, which is small to intermediate size. This one is big one. So what shall I do about pericardial cyst in terms of management? I want to hear from you. What do we do? Guys, is my sound clear?
Yes, clear. Okay. If it's not need intervention, since if it's so large and causing compression sign, it needs excision.
So if you raise your voice, شوية.
If it is small, not need treatment.
Okay.
If it's large and causing compression sign, it need to be excised.
Very good. Very good. This is exactly what it is. So if it is innocent bystander incidental finding, why should we bother? But if it's compressive, okay, then we might need to do something about it. And do you think aspiration is enough?
No.
No.
Why?
Exactly. Because it's a congenital deformity of the pericardial sac. So whatever you drain is gonna refill again, okay? So you have to excise it surgically, okay? Like this one, this is an excised pericardial cyst. Surely it has been taken out for a reason, which is compression, okay? And this is how it looks like, okay? Now we come to constrictive pericarditis, which is considered by so many fellows to be one of the tedious and hard topics in cardiology, given the imaging data is a lot, the clinical data is variable, and the management tracks are not so clear. So let's find out constrictive pericarditis. Now for this chest X-ray, we are seeing a calcification here. This is a rim of calcification, and if you follow it, it's almost all on the right border of the heart. Okay, left border of the heart. See this one, and down here. Okay, now in the lateral, you are probably gonna see it even better, even better. So scan calcification is seen better in the lateral than in the APPA view of chest X-ray. Okay. So if you are suspecting pericarditis, constrictive pericarditis, and you are looking for calcification, you better order a lateral X-ray. Okay. Now, is all calcification, or is any calcification we see in the chest X-ray upon the heart shadow is pericardial? Like here, what is this? This is also pericardial calcification, this one here?
It's annular, mitral annular calcification.
Yes, this is mitral annular calcification, MAC. Okay, this is the typical location and the typical appearance of MAC. Okay. Now, what about this calcification here? See this calcification? And it's here in the lateral X-ray. Guess.
Aortic valve. Coronary.
Coronary calcification. Exactly. This is coronary calcification. Okay. So be careful. It's not that all calcium is pericardial calcification. Okay. So here, see, this is LAD calcification, which is seen, of course, much better in fluoro than in plain X-ray. And also the pericardial calcification is probably seen better in fluoroscopy than in X-ray. You see, this is pericardial calcification. This is how you see the calcification in fluoroscopy. Okay, so you see the calcification this way. Now, what is this calcification? What is this calcification? This is left atrial calcification. And sometime in chronic LA dilatation and hypertension, remodeling, fibrosis, calcification, you know, and the left atrium remodels by calcification as such. And now what is this? What is this?
Aneurysmal calcification.
Exactly. So this is not pericardial calcification because it is, you know, we are seeing kind of a structure sticking out of the cardiac silhouette. It's not obeying the geometry of the heart we know in chest X-ray. So this is an out pouch. This is an aneurysmal apex, and it is encircled by a shell of calcification. So this is an aneurysmal apex with calcification. Okay. So the message here is calcification, pericardial calcification can be seen by chest X-ray, better in lateral than APPA, but remember there are some other causes for calcification you have to be aware of. Remember, I have showed you this slide in the first presentation, and this is a calcified pericardium, and this is fibrotic thick pericardium. And we said that the normal pericardium thickness is less than 2 millimeter. If it is more than 4 millimeter, that is towards the diagnosis of constriction. If it is more than 6 millimeter, the specificity for the diagnosis of constrictive pericarditis becomes really so high. And remember, in a large or relatively large series of constrictive pericarditis patients, who manifest clinical features of constriction and echo features of constriction when they further worked up by cardiac CT and stuff like that. They found out that 18% of these patients have normal thickness pericardium. 18%. So normal thickness of the pericardium does not rule out constriction. Okay? Good. Now, if you see the cardiac CT, okay, now I'm gonna point to some structures and I want you to guess, what are they? What is this?
Coronaries.
Coronaries, it's close to the circ, but it's, you know, in a different structure than the epicardial surface. The coronaries are on the epicardial surface, but this one is deeper in the atrioventricular junction. So what could it be? It is
Annular.
exactly. This is a mild form and degree of mitral annular calcification. Of course, you can see much more exuberant calcification and MAC than this, but this is one form of MAC. Okay. Now, what is this? Now, this is exactly in the epicardium, in the epicardial surface, is not in the muscle, not deeper. So, what could that be?
Visual, pericardium.
No, it's a coronary artery. This is a coronary artery, which is what? This is the what? RCA, okay? The right side is here, the left side is here. So this is RCA, okay? So this is RCA, this is MAC. So why the RCA looks like that in an X-ray? Because of calcification. If we assume that this is non-contrast CT, you know, but I think this is contrast CT actually. I'm not so sure. It looks like contrast CT. Now look at this here. This is structure here. What is this? And if you follow it, it's kind of circumferential filling around the heart. Could be effusion, but the texture is different than effusion.
Epicardial fat.
Exactly. Thank you so much. So this is epicardial fat. Is it thick? Yes, it's thick. It is expected to be lesser than that, but this tends to be stout shوية. Okay, so this is thick epicardial fat, but this is the epicardial fat. Now, where is the pericardium? This is the pericardium. This one here is the pericardium. So it looks so nice and clean in cardiac CT, and you could assess for the thickness, the calcification, the circumferentiality of the calcification, and all of that. Now we have another fat that we can find above the pericardium, which is this one here, and this is called what? Pericardial fat. So we have epicardial below the parietal pericardium and pericardial above the parietal pericardium. Okay? Now, look here. This is exactly how the constrictive pericarditis, when it turns into calcific, axial calcification. You see how calcified it is? Look at the epicardial fat here, a small pad here. It's not like the one we have shown earlier. You see the epicardial fat, small rim, okay? You see the pericardial fat is here. And this is the parietal pericardium, which is extensively calcified. And even you see on this part, around or in the vicinity of AV junction, the calcification invade the muscle maybe. And this is important, by the way. يعني الآن نحن لما we diagnose constriction based on clinical data and preliminary imaging data, which is echo, we still need to go for cardiac CT. okay, for different reasons. لكن من المهم جدا نعرف البريكارديوم thickness, calcification, and how much extensive, and also we need to know how much it invades the muscle. لأنه this makes the surgery يعني of a different approach. صح؟ يعني لما يكون عندك pericardial thickness invading the muscle, when you come to this area, you have to be so careful. Yani the surgeon has to exert maximum care and caution when he deals with this area by stripping the pericardium, okay? Yani digging through the calcium, invading the muscle is a bit tricky. The surgery, all in all, is very difficult surgery with a high mortality rate approaching 8, sometimes more than that, approaching 6% actually. فالمورتاليتي isn't يعني حاجة mild, it's big deal actually. Right. Now, how do we diagnose constriction by echo? We have the basic 3 findings and some other ancillary findings. The 3 basic findings I wish all of you to be aware of are respiratory related ventricular septal shift, which is septal bounce. Preserved or increased medial annular velocity compared to the lateral. Hepatic diastolic flow reversal with a specific pattern that we are going to discuss shortly. Now, the rest are the state of IVC, the mitral valve flow respiratory variation, the septal shatter, the pericardium thickness and calcification, and the chamber's contours. Okay, so these are the data you are going to gather in echo. As many or as much of data you could gather, the more into the specificity of the diagnosis you will be, right? So let's find out. Now, for constriction, we have interventricular interdependence. And I want you to change this statement to be more precise. Somebody said, in constrictive pericarditis, there is interventricular interdependence. Is this an accurate statement? Is it accurate?
No.
Type. Can you correct it to be accurate?
There is enhanced interventricular interdependence.
Thank you so much. So there is some physiological degree of interventricular interdependence. Meaning what? Meaning the two ventricles relies on each other in the filling. Okay, so the filling of one comes at the cost of the other and vice versa. That is normal, but subtle, small degree. Now in constriction, this becomes robust, enormous, and pronounced. Okay, why does that happen? Because the heart is constrained from the exterior. So they no longer expand, so they rely more heavily on the septal excursion. So they rely more on this one. So the filling of one comes at the cost of filling of the other. Okay, so during inspiration, what happens? We have more flow that comes to the right atrium, to the right ventricle, more of septal shift to the left side. Okay, more septal shift to the left side. Now, during inspiration, what happens in the left atrium? Do we have more flow or less flow compared with expiration? Right, left atrial blood, does it increase during inspiration or expiration, and why?
Increase during expiration.
With expiration. And it decreases with inspiration. صح? Why it decreases during inspiration? Why the blood flow and the volume of blood, the venous retain to the left atrium decreases during inspiration? This is physiological. Why does that happen? That happens because during inspiration, the lungs are inflated. The blood pools inside the inflated lungs, and less of blood flows into the left atrium. During expiration, the lungs shrinks and they push more blood into the left atrium. So you have more volume of blood coming to the left atrium during expiration and less blood coming during inspiration. So يعني معناته ببساطة عندنا كالآتي. During inspiration, okay, we have less blood, or let's say less volume, venous retain, less venous retain. Okay. Now, what determines the flow from the left atrium to the left ventricle is what? Is the LA minus the LV gradient, right? So the difference in pressure between the left atrium and the LV determines how much of blood goes from LA to LV, right? Now, during inspiration, we said we have lesser venous retain. So the LA pressure is down, is a bit down. But without constrictive pericarditis, usually during inspiration, the LV obeys the thoracic wall pressure swings. So it relaxes better and the LV pressure decreases also. So the gradient remain reasonably maintained. But now in constriction, what do we have? We have LA pressure decreases, okay? But what about the LV pressure? The LV pressure no longer is isolated from the thoracic cavity pressure changes. So it no longer dilate better or relax better in inspiration. So the gradient remain as it is, And this makes what? Makes the flow of blood from the LA to LV during inspiration is less than during expiration. So there are two factors why the blood flow into the LV during inspiration is lesser than during expiration. One is that the septal bounce during inspiration shift the septum to the left side, minimizing the LV cavity. So the relaxation is going to be impaired, no much of relaxation, a smaller cavity, no much of accommodation of blood. Factor one. Factor two, the gradient between the LA and LV is decreased. Therefore, less blood flows during inspiration. Okay. Now, what happens during expiration? The flow increases here, and the septum goes to the right side. So the flow improves during expiration in comparison to inspiration. This is the interventricular interdependence. So do you get it? إلى حد ما صح؟ معقولة كده يعني؟ والله صعبة لسه. طيب. Okay. تمام. So can we move on? صوتي واضح؟
Yes, clear.
Yes.
تمام. هي مشكلة الزوم مرات يلوز كونتاكت مع الناس وكذا، فما بتعرف هل انت لسه اونلاين ولا اوفلاين، فاذا في اي مشكلة في الساوند let me know. طيب. Now, can anybody describe this echo here? This one. This is apical four-chamber, right? Right? Apical four-chamber. طيب.
Yes.
What do we see in this apical port chamber? We are seeing dilated atria.
Yes, biatrial dilation.
Okay, what else?
Subtle motion.
Very good. What else? Do you see here? There is something here. This part here and this part here.
The LV is the ventricles are compressed from outside.
Exactly. Exactly. So, like you said, the atria are the ventricle are compressed from outside. You see, now the heart is kind of wasted. You see, like if the heart supposed to be geometrically goes this way, and this is the left atrium. Now what we are seeing is the heart that goes like elongation like this. When we come to the atrioventricular junction, it tends to waste like that. Instead of going this way relaxedly, it is constricted at the waist or at the base of the heart this way. This is an extreme form of constriction. Usually يعني ما تتوقع انه في الايكو you are gonna elicit this one frequently. This is an advanced case of constriction when it affects the geometrical alignment of the ventricle and cause this kind of geometrical distortion. Okay. ولكن بنشوفها ايضا يعني اللي هو دي اللي انا قلتها لكم هنا chamber contours. Okay, one of the data we will look for. Now, if you look here at the lateral, طبعا we take the velocity at the lateral annulus and at the medial annulus. Okay, this is the velocity at the lateral annulus, which is here. It is 12.5. Now we take the is it 12.5? Now we take it at the medial annulus. It is what? 12. If this is normal or abnormal, are you expecting the two velocities, medial and lateral, to be equal and different? And if different, in what way?
It's different in normal.
Yes, in what way?
Yeah, the lateral annulus moving more than the medial annulus.
Why?
Because it's free.
Thank you so much. Because if you look here, يعني بس الآن بس بسهولة كده common sense. Take this point out. I'm gonna take it out. I'm gonna find إنها it is attached to this wall and this wall. It is free at least on this direction. صح؟ حتى even if I consider it's also attached to this. So it is free at one level. Take this one out. It is attached to cardiac skeleton in the four directions. So it is more tethered by the cardiac skeleton. So this one is more free to move than this one. That is why physiologically the lateral annular velocity is faster than the medial annulus. Now in constriction يا دكتورة اللي بيحصل ايش؟
Restriction of the lateral movement, including in the medial movement.
Yes.
Because it's restrict movement by the calcified and distinctive pericardial.
Exactly. So when you have constrictive pericarditis, what do you have is a calcified fibrotic pericardium overlying the medial annulus. So it becomes more tethered than the medial annulus. So it goes slower. Okay, it goes slower. So this one becomes slower. And sometimes the medial annulus tries to compensate for the slowness of the lateral annulus by undergoing a compensatory hyperkinesis. A compensatory hyperkinesis. So sometimes it can be even much higher in terms of velocity than the lateral annulus. This concept and idea is referred to as what? Annulus
reversus.
Reversus. Okay. Great. Now, if we take the hepatic venous Doppler, this one is, see, with the A wave, we have this reversal. So this reversal is what? Is it systolic or diastolic? It is diastolic. Diastolic reversal. So let us follow this diastolic reversal. I'm following it up. So it is kind of up and down. Let's time it with the respirometer and see. Is it increasing during inspiration or expiration? Look. Okay. It's increasing during what? Look here. Now,
Inspiration.
This is inspiration. This is the inspiratory phase. And this is the tracing, the corresponding tracing. This one. And now this is the expiration here. And this is the corresponding tracing. So it increases during what? Expiration. So this is called what? It is called increased or enhanced or sometimes exaggerated expiratory diastolic flow reversal. Now in the exam, when we ask, we hear so many different answers. Diastolic reversal. There is diastolic reversal. Of course, there is physiological diastolic reversal. Now somebody said there is increased diastolic reversal. It's still incomplete answer. There is an increased diastolic reversal during expiration. So expiratory, enhanced or increased or exaggerated diastolic flow reversal. That's the complete right answer. ودي بتحصل ليه؟ simply يا اخوانا شوفوا مثلا تخيلوا معي during expiration ايش اللي بيحصل؟ There is a blood in the right ventricle, right? And a blood in the right atrium. Now during expiration we said that the septum is gonna shift where? Left or right during expiration? Is gonna shift where?
To the right.
To the right. Powerfully, it's gonna shift to the right. When it's gonna shift to the right, that's gonna what? Increase the backflow into the liver and decreases the forward flow. Okay, and during inspiration, now the flow goes easy because now the septum belongs to the RV and again it's the LV, so there is no much of backflow. Okay, so physiologically think of it as what is the actual mechanism of constriction that leads to increased diastolic flow reversal during expiration? It's the septal shift. Okay, good. Now this is an important echo data as to constriction. Important. Okay. Now, what are we seeing here? Look here and focus on the septum. Focus on the septum. You see there is septal what? Septal
bounce.
Exactly. And here also, if you focus thoroughly and carefully and for some time, you are also going to appreciate septal bounce. Okay. And we said septal bounce is a respiratory movement of the septum. And therefore, we need to have a longer tracing. يعني 3 beats is not good. We said we need 10 beats to appreciate it fully and not to miss it. Okay? Because if you need to capture 2 respiratory cycles, you need 10 cardiac beats. Okay? So you have to have a longer beat acquisition. Okay? This is important. The other thing about septal bounce, because it might be so subtle and we are not so accustomed to seeing subtle excursion, our eyes is not that great. So there is another echo modality we can use that's gonna show this septal bounce even better than 2D. What is that modality? What is that modality?
M mode.
Exactly. Thank you so much. The M mode, I'm going to show you the M mode. Now, what is this here? We have, look here at the RA pressure and follow it. The RA pressure increases during inspiration. And this is in contradistinction to the physiological situation where the pressure of the right atrium is expected to drop during inspiration. Now we have an actual rise. What is this sign? What is this sign? When you have an increased RA pressure during inspiration. Instead of cosmol. Yeah, this is cosmol sign, which is one of the clinical and hemodynamic signs of constriction. Now, do we need invasive hemodynamics? Do we need invasive hemodynamic to diagnose constriction?
Sometimes.
What are these sometimes?
In present, like normal pericardial sickness.
Okay.
If the echo failed to confirm constrictive physiology.
Okay. يعني معناتها إذا عندنا conflicting data، يعني مثلا البيشنت clinically the patient that look like constriction, we may have a thick pericardium, but echo fails to demonstrate the full-blown features of constriction. And by the way, we have to be so sure. ليه؟ لأنه surgery is so costly and the risk is so high. So if we have to drive the patient to theater for pericardial stripping, we have to be dead sure that he has constriction and dead sure that when we do the stripping, the patient's symptomatology is going to improve. Okay? So this is important. In conflicting controversial cases, you know, we sometimes need invasive hemodynamics. But what are we expecting to find in invasive hemodynamics in constrictive pericarditis? طيب 3 حاجات. 1 2
enhanced
and 3. طيب يلا دكتورة. 1 is what?
The enhanced interventricular interdependence.
And that is seen as what?
The pressure.
Yeah.
The pressure changes with inspiration and expiration between the LV and RV.
Okay. Exactly. And this is here in the invasive hemodynamics, we call it concordance and discordance. Discordance means enhanced interventricular interdependence. Discordance. Meaning what discordance? Meaning when one ventricle goes high, the other goes low. That is the enhanced interventricular interdependence. So look here, when the LV goes low, the RV goes high. Okay? When the LV goes high, the RV goes low. So this is discordance. This discordance is the invasive hemodynamic tracing of enhanced interventricular interdependence, which is the important mechanism of constriction, the pivotal mechanism of constriction. Okay. 2, what do we see? the dip and plateau, which is here, the dip and plateau. And sometimes they call it a square root sign. So the diastolic curve here goes so swiftly down and then like this. And this indicates sort of high pressure filling. Okay. 3. Look at the diastolic curve of the LV and the RV here. Do they coincide? Yes, they do coincide. If this is physiological, no. Usually the diastolic pressure on the LV is more than on the RV, so there is a gradient. We are supposed to expect a gradient here between the LV and RV because they are not equal in diastolic pressure. But this equalization of the diastolic pressure of the two ventricle is because now the ventricle, both of them are encased in a tough pericardium, so their diastolic pressure becomes semi-equal or nearly equal. Okay, so this is equalization of diastolic pressure. So the discordance, the dip and plateau, and the equalization of diastolic pressures. Now, when we look at restrictive cardiomyopathy, it might also give us dip and plateau, less of equalization, لكن أهم ما في الأمر إنه بيكون في what? Concordance. يعني when this goes high, this goes high. When this goes low, this goes low. This is concordance. Because there is no enhanced interventricular interdependence as in constrictive pericarditis, which manifests discordance. So remember, concordance and discordance. Okay. Now, in COPD, do we have septal bounce? Yes or no? In COPD, do we have septal bounce?
No.
We do have septal bounce. Yeah. In COPD, do we have cosmal sign?
No.
Really? Yeah, we have. In COPD, do we have respiratory variation across the mitral and tricuspid valves that is supraphysiological? Yes. So in so many ways, COPD looks alike مع الكونستريكشن. طيب تخيلوا مصيبة أنه a patient of COPD is taken for surgery على إنه constrictive pericarditis. Big shame, صح؟ ولذلك we have to make sure we are not dealing with COPD. And the easiest way out is to look at the IVC or SVC flow. Can you tell me about the difference here? The big difference between COPD and constrictive pericarditis? This is hepatic venous Doppler. طيب لاحظوا معي in COPD
no flow reversal.
Huh?
No flow reversal.
لا, there is. Look at the expiration, the flow is here. Look at the inspiration, the flow is here. So in COPD, we also have an increased expiratory flow reversal, just like what we have in constriction. لكن الفرق below the baseline. Look at this part here and this part here. This is the forward flow. The flow from the liver, the SVC, the IVC towards the right atrium. It is fixed and doesn't change a lot with respiration in constriction, you see, but it manifests major swings in COPD. So during inspiration, you see how it increases, and during expiration, it goes so low. This is COPD for sure. In constriction, the forward flow is fixed. In COPD, the forward flow increase enormously during inspiration. Okay, this is a major distinctive features between these two entities which look alike otherwise. Okay, good. Now طبعا الكونستريكشن ريستريكشن بيظهر في الاكزامز وفي الاورال اكزامز يعني بطريقه شويه is disturbing يعني. Usually they tell you, you know, which is which. يعني هي الفكرة الأساسية وين؟ لأنه في some similarities between the two, and they want to make sure that you are not going to decide about a patient of restrictive cardiomyopathy to go for surgery for pericardial stripping. I know that will be big shame. عشان كده we have to be so sure that this patient is really having constriction and not restrictive cardiomyopathy, and of course not COPD. So these are the different features between COPD and between restrictive cardiomyopathy and constriction. الحاجات المهمة اللي أنا عايزكم تلاحظوا ليها هي دي. الاتريال size. It tends to be bigger where? In this is restriction and here is constriction. So the atrial size tends to be bigger where? In restriction than in constriction. Okay. Now the mitral flow pattern is restricted in both. So you can have what looks like grade 3/4 diastolic dysfunction in both. So the flow pattern across the mitral valve isn't so much discriminatory. Now the respiratory variation in E wave is more significant in constriction than in restriction. And the mitral annular diastolic velocity, okay, the medial, here we mean the medial. The medial tends to be high in constriction and low in restriction. Now, B-type natriuretic peptide tends to be higher in constriction, in restriction than in constriction, because this is a stretch marker and the heart is more stretched in restriction than in constriction. In constriction, actually, it is prevented to stretch. It is prohibited to stretch out because of this pericardial, okay? Now, pulmonary artery systolic pressure tends to be higher in restriction, okay? And the equalization of the pressure between the capillary whicher RA pressure tends to be more pronounced in constriction than in restriction. You remember the equalization of pressure, which is here, this one. The equalization of the diastolic pressure, this is the diastolic stage between the RV and LV, tends to be actually 0 here and 5 and above here. So constrictive pericarditis kind of eliminate the diastolic differences between the two ventricles. Okay. Now the reciprocal variation in which is concordance. This is the concordance and discordance. This one is discordance. So the discordance in pressure between the LV and RV is a manifestation of what? Constriction. And it is absent in restriction. And again, just to make sure that you understand this one, the discordance means the LV pressure low, the RV pressure is conversely high, and vice versa. So it is discordance. This discordance is a sign of constriction, not restriction. Good. Now, one of the major things we usually tend to ask a lot in the exam is these two. The diastolic, the pulmonary artery systolic pressure and the atrial size. So we ask the atrial size is bigger where? In restriction or constriction? In restriction. And the pulmonary artery systolic pressure is higher where? In
restrictive cardio.
Yes. Okay. So now look here. During inspiration, that is inspiration here. Look at the septum, how it goes. It is mild going leftward. This is left. This is the RV here. So what are we seeing here? This is septal bounce by M mode. So the septum goes towards the left ventricle in inspiration and towards the right ventricle during expiration. What else do we notice here? This undulation, you see, is not straight. There is lots of excursion here. This is called septal shutter, and it's also a sign of constriction. And I'm not gonna bother you about what is the exact mechanism of this. You can go and dig and read about that, but this is also one of the signs. So in the septum, you are gonna see two types of excursion. One is non-respirophasic beat-to-beat septal shutter, and another one which is respirophasic septal bounce. So when you look at the septal shutter, it's happening each and every single beat. You see this? Okay, every single beat. But the septal bounce is seen like respirophasic, like this. Okay? So the septal excursion in constriction, two types, septal bounce, which is more common, and septal shutter. Look at the septal bounce here, which is much more pronounced than the example I showed you. See, it is here and here. Now, what is this here? Inspiration or expiration, this phase, this part? Is what? Inspiration or expiration?
Expiration.
Expiration, exactly. And this one is? This part is?
Aspiration, moving toward the LV.
Exactly. So this one here, you see the LV, the RV is wider during inspiration and is narrower during expiration, and the opposite for the LV. So this is septal what? Septal bounce. Now, the annulus reversus, when we look at the medial E prime, which is expected to be, like we said, physiologically is expected to be slower than the lateral E prime. Now we are seeing exactly the opposite. So we are seeing the medial E prime is here and the lateral E prime is here. So this is called annulus reversus. Reversus معناتها is the reverse of the physiology. Reverses. ومرات في ناس بيقولوا annulus paradoxus ومرات ناس بيقولوا annulus inversus. في جارجون كتير في الحتة دي يعني. لكن the right terminology is annulus reversus. Annulus reversus. One of the specific features of constriction. Now, if you have septal bounce and medial E prime velocity more than 10, more than 9, and hepatic vein expiratory diastolic flow reversal high. These are three features of constriction. Now, if you have the three of them, the specificity of diagnosing constriction is 97%. لكن the sensitivity drops to 64. لكن تخيلوا إذا if you elicit the three of them, 97% specificity for the diagnosis of constriction. Septal bounce يعني دي. This one, 1, 2. This one, 3. See? This one. If you demonstrate these three signs, diastolic flow reversal increase during expiration. 1, 2, septal bounce. 3, annulus reversus. So these are the major three features. You have to dig and look for them really carefully, because if you elicit the three of them, the diagnosis of constriction is specified by the degree of 97%. Okay. Now, what is annulus paradoxus? Anybody knows annulus paradoxus? Annulus paradoxus. طبعا بعض الناس بيستعملوا الانيولس paradoxus synonymous to annulus inversus، ولكن عشان نكون شوية careful, it's a different terminology. Yes, it is related to constriction, but it's different than annulus inversus or reversus. So what's the difference? The difference of the annulus paradoxus is the, look here, it's the paradoxical to the positive correlation between E and E prime ratio and the pulmonary capillary wedge in patient with myocardial disease. An inverse relationship was found in patient with constrictive pericarditis. يبقى ال E وال E prime ratio, E over E prime ratio. That indicates what? ده نحن بنستعمله as a surrogate marker of what? Of the pulmonary capillary wedge pressure, right? كل ما دي bigger high معناته ال pulmonary capillary wedge is high. صح كده؟ That's in non-constriction situation. اللي هو that's what we see. E over E prime ratio linearly correlate or is proportionally related to the pulmonary capillary wedge pressure. طيب اللي بيحصل شنو في الكونستريكشن؟ اللي بيحصل شنو في الكونستريكشن؟ في الكونستريكشن اللي بيحصل لانه نحن في ال E over E prime, what are we using? We are using E from the mitral inflow and E prime from where? From the medial. And we said إنه المedial E prime in constriction, it goes high, so it makes the ratio low. It makes the ratio low, despite having high pulmonary capillary wedge pressure and high LA pressure. So the E over E prime no longer correspond linearly or proportionally with the pulmonary capillary wedge. In fact, the reverse is happening. The reverse. ليه؟ لأنه تخيلوا معي في الكونستريكشن كل ما زادت الكونستريكتيف pericarditis mechanism holding on the heart كل ما زاد ال LA pressure. صح؟ كل ما زاد ال LA pressure معناته كل ما زاد what? This one. This one is gonna increase. Where is this one? This one is gonna increase. صح؟ كل ما الكونستريكشن زاد على الهارت كل ما الديastolic dysfunction زادت على الهارت كل ما البلمونري كابيلاري ويدج زاد. لكن بنفس الوقت كل ما الكونستريكشن زاد we are expecting the E prime velocity to increase, this part to increase. So the ratio is gonna go in the opposite direction to the pulmonary capillary wedge. It's gonna go like this, inversely proportional. Okay, so as the E over E prime goes high, this goes low. And as the E over E prime goes low, the pulmonary capillary wedge goes high. This is called annulus paradoxus. يبقى الآن in constriction we have annulus reversus. دي بس خلوني أعمل ميوت.
في نقطة كده بس ما.
Okay. Yeah, sure. Go ahead. Yeah, go ahead. النقطة إيش؟ I muted you.
ايوه الاي برايم هي corresponding لشنو بس عشان اقدر استوعب الكونسبت.
الاي برايم. اوكي الاي برايم اللي هي دي تمام. this wave is called E prime and this wave is called A prime. A prime. During the atrial filling, the passive phase of atrial filling, الannulus goes where? It goes down. لأنه الheart is relaxing. So that is the medial E prime. During atrial contraction, it also goes down again, like into a lesser degree, and that is A prime. So this is the relaxation of the annulus with the passive filling, and this is with the atrial contraction. Relaxation of the annulus. Now, when we have constriction, أو في ال E over E prime, ال E over E prime معناته إيش؟ E من الميترال inflow and E prime from here. Usually لما يكون عندك diastolic dysfunction, as the diastolic dysfunction advances, an E wave of the mitral inflow tends to be what? High or low?
Low.
كل ما diastolic dysfunction زادت الميترال inflow الميترال inflow اللي هو فيه E and A. E and A. Not E prime and A prime. فيه E and A. كل ما diastolic dysfunction بيحصل شنو للإي؟ بتزيد ولا بتنقص؟
Increase.
Exactly. It goes higher. And the A goes lower. Now, as diastolic dysfunction advances, اللي بيحصل شنو للميديال E prime؟ It goes lower. It goes lower. يعني إذا physiologically it's like that, during advanced diastolic dysfunction, it goes so low. لأنه relaxation is so impaired, so it becomes like that. So, معناته as the diastolic dysfunction advances, we have more E and less E prime. So the ratio of E over E prime is going to increase with the increasing diastolic dysfunction. Okay, good. Now in constriction العكس بيحصل لأنه كل ما زادت الديastolic dysfunction الإي بتزيد لكن الإي برايم كمان بتزيد في الكونستريكشن only in constriction. فبالتالي الريشيو دي tends to go in the opposite direction to the diastolic dysfunction. ودي اسمها الannulus paradoxus. Okay, so from linear correlation between the capillary wedge and E over E prime in physiological conditions, it becomes paradoxical relationship in constriction. Okay, good. Now look at the strain. This is a strain of a patient of constriction. Look هنا على الstrain في lateral part is impaired. Why it's impaired in the lateral part? Because the lateral part or the lateral wall is the most affected by constriction, right? The most affected by constriction. Well, this is the same patient after pericardiectomy. You see there is revival of the lateral strain. Now the lateral wall is coming back, okay? I'm gonna skip this one and this one too. Now look here. This is important, really important. So try to focus here. Because these are all signal from hepatic venous Doppler. So what are we seeing here? Inspiration, phase, expiration. So that's the diastolic reversal. Let's compare. This one is increasing during inspiration. So we have what? We have increased diastolic flow during inspiration. This is restrictive cardiomyopathy. Now in constriction, what do we have? expiratory flow and inspiratory flow. So what do we have? We have increased diastolic flow during expiration. Okay? So this is important distinction between these two. Now, what is this here? This is diastolic flow reversal, which is fixed, is not subjected to respirophasic changes. This is in pulmonary hypertension. And in a later presentation about diastolic dysfunction, we might explain why do we have this in particular with pulmonary hypertension. Of course, in tricuspid regurgitation, when it is severe, we have systolic reversal, systolic. So this systolic part is gonna flip upward instead of downward. That is tricuspid regurgitation. But the most important two are this one and this one as far as this lecture is concerned. In restrictive cardiomyopathy, you have an increased diastolic flow reversal during inspiration, and in constriction, you have increased diastolic flow reversal during expiration. Now, this hepatic venous Doppler is suggestive of constrictive pericarditis, restrictive cardiomyopathy, AVD association, tricuspid stenosis. What do you think? طبعا للأسف أنا ما جايب لكم respirometer, ولكن if you focus هنا we have 1, 2, 3. Usually 3 beats doesn't correspond to respirophasic changes. So these are not respirophasic changes. So how come we have this diastolic reversal and this much of diastolic reversal, and this has nothing to do with respirophasic changes? So it is not restriction and it is not constriction. And it is variable. In tricuspid stenosis, we may have high diastolic reversal, لكنه بيكون fixed. لأنه tricuspid stenosis is fixed. Now we have one that is very high and one that is so different. This is what?
AV dissociation, most probably.
Thank you so much. You know the Cannon waves? The Cannon waves, when you have an AV dissociation, when the tricuspid valve contracts against a closed, when the right atrium contracts against a closed tricuspid valve, the pressure is going to be so high, and the back pressure in the hepatic venous Doppler is going to be extremely high, as high as this one. Okay? And it is intermittent because it depends on the dissociation and this kind of contraction. Okay? So it happens at occasions and it doesn't happen at others. This is Cannon waves, okay? Now, pericardial agenesis, I'm gonna walk you quickly because we have short part to come and gonna take a long time. You remember we said the pericardium is not essential for normal lifespan, right? So can we have pericardial agenesis? Complete absence, yes. The heart tends to go more leftward, like this one here, and the chamber tend to be a bit dilated, okay? And they call it a Snoopy sign. The heart looks like a Snoopy sign because of this rotation, okay, from its normal axis when there is pericardium. This is, you see, the heart in the long parasternal. It becomes tricky to get the image as you used to get. And the chamber tends to be a bit dilated like this. Now we can have absent pericardium, complete agenesis, or partial agenesis. So we can have a small area of the pericardium or of the heart is devoid of pericardium. Now, guess which is potentially more serious? The partial agenesis. Why?
The partial.
Why?
Can constrain the ventricle.
To close certain areas in.
Exactly. لأنه البارشال absence ممكن يعمل herniation. يعني لما يكون عندك pericardium all through the heart except for an area like this one here, it can herniate. لأنه pressure هنا is different than this one. This tends to be loose and resilient and not much of pressure overlying this segment, so it can bulge out. بيحصل لك herniation and entrapment. Okay? وده اللي بيحصل مرات. الآن مثلا look at this LAD course. This LAD, how could you explain this LAD course? غريبة شوية صح؟
Absence of pericardium in the distal area or apical area.
Exactly. طبعا في answer that was presented by one على إنه this might be stitch, surgical stitch. Yes, it can be. It can be surgical stitch. Yeah, I agree with that. لكن it doesn't look like the conventional atherosclerosis we see. لأنه في distortion of the course. It dips this way, and it is obstructed here. So the handsome explanation is exactly if you consider that you have like an artery going this way, it's gonna do this way, right? So it will come this way, it dips here and it comes this way. So it's gonna be kinked here. So this is herniation part of the apex due to partial absence of the pericardium, leading to kink and obstruction of the LAD. Okay, that is why partial absence of the pericardium can sometimes be more serious. Potentially, yeah. Now, pericardial fat, I don't think we need to discuss this one. And okay, so quickly, absent pericardium is not compatible with normal lifespan. Yes or no?
No.
No.
No. Patient has cancer with mets to the heart. Which of the following is true? The mets will most likely be intracavitary mass, i.e. it seeds into the endocardium. The mets has predilection to the pericardium. The mets will be complicated by transudative pericardial effusion. The mets are more likely from a melanoma.
Most likely from a melanoma.
Okay. Any other?
B.
The
has
mets
predilection to pericardium.
to pericardium.
Exactly. We said that the melanoma has a special affinity to the heart. But if I ask you, we have this heart and we find mets, what is the most common likelihood this mets comes from?
Lung.
It comes from the most common malignancy.
Most common cancer, breast or lung.
Exactly. But if you have melanoma, things are different. Yeah, melanoma is gonna seed in the heart preferentially. لكن لأنها it is really rare tumor, so mets on the heart are most likely coming from common malignancies. 85-year-old male had stabbing chest pain, which increased on lying flat and mitigated by sitting and bending forward. So clear pericarditis. There is an antecedent flu-like symptoms. Which of the following is true? Elevated troponin indicates acute coronary syndrome. ECG will show T-wave inversion. Echo will show large pericardial effusion. He will need colchicine for 3 months.
You will need
D.
colchicine for 3 months.
Exactly. مع إنه قد تقول إنه الcolchicine is not the protocol and stuff like that, but this is the most appropriate answer here. إنه colchicine. Okay. Now this chest X-ray shows hiatus hernia, artifact, pericardial calcification, pericardial cyst, raised hemidiaphragm.
Pericardial cyst.
Pericardial cyst.
Exactly. Now, this is an ECG sign of a patient with pericardial effusion. The ECG shows complex to complex voltage variation, which indicates a means pulsus alternans, pulsus paradoxus, large pericardial effusion, tamponade, pulsus deficit.
Large pericardial effusion.
Okay. Come on.
This is electrical alternance.
Exactly. So why not pulsus alternans?
Pulsus alternans is a clinical sign of severe LV dysfunction.
Thank you so much.
Yes.
طيب, why not pulsus paradoxus?
Also,
like
paradoxus clinical sign of tamponade.
Is blood pressure drop during
Blood
inspiration
pressure.
in a patient of tamponade?
Yeah.
Exactly, exactly. So what is this sign called?
Electrical alternate.
Which indicates large pericardial effusion.
Right,
Great. Thank you so much. Now, a 45-year-old gentleman presented with the following clinical and echo signs. See images. I'm going to show you the images. Here are, you see, we have cosmal sign and we have septal bounce. So what is the next course of action? Send for surgery, order cardiac CT, start the patient on a short course of steroid, follow up in 6 months.
CT, cardiac
Exactly.
CT.
يبقى معناتها لاحظوا معي هذا البيشنت presented with these clinical features of constriction and this septal bounce. So the next response is, or the next best course of action is to do cardiac CT. And if cardiac CT showed calcified thick pericardium, that's the diagnosis of constriction, is established based on clinical and multi-modality imaging data. And I think patients should go for surgery. Like you cannot send patient for surgery based on echo alone, because we said we have to confirm the diagnosis by the anatomy of the pericardium on one side. Besides, we also, the surgeon is so curious to know about the state of the pericardium, and that's going to dictate his surgery and how he does it. Okay? Come on. Now, this patient has been admitted for a week for viral pneumonia and is recovering now with stable hemodynamics and no symptoms apart from fatigability. He is due for discharge next morning. What is the best course of action? Pericardiocentesis for diagnostic purposes, close clinical supervision, therapeutic pericardiocentesis, go with the discharge plan.
therapeutic pericardiocentesis.
Okay. Okay. طبعا بالمناسبة أنا لو قلت therapeutic pericardiocentesis, that's not absolutely wrong. We do it sometimes. يعني patient إذا عنده large pericardial effusion, and حقيقة I'm advocating this policy of being proactive rather than reactive. So if you have large effusion and if the patient fits, no high risk of sticking a needle there, why not to drain before you wait and see until the patient recovers or unfortunately might swing into cardiogenic shock. Okay. But for the usual expected answer here is close supervision.
Clinical supervision.
Exactly, clinical supervision. Because you have large effusion, but the patient is stable. So you can be vigilant, keep an eye, and see. Okay? Lakin, by the way, going proactive isn't wrong at all. بالعكس. Yeah? And I don't consider C as a wrong answer. Now, a 54-year-old male, no past history of note, currently asymptomatic. He did this chest X-ray as part of employment checkup. His physical exam is unremarkable. What is the next step? Reassurance, echo, cardiac CT, follow-up chest X-ray after 6 months.
Cardiac CT.
Okay. Cardiac CT. Any other?
We do an echocardiography.
Echo.
Yeah. هي طبعا في hierarchy صح؟ في hierarchy. يعني if chest X-ray or if clinical data suggestive of constriction, the next step is echo. Then cardiac CT. Okay? لأنه أنت you want to elicit the hemodynamic data of constriction before the anatomical data. Okay? The hemodynamic data is provided by echo. Cardiac CT does not provide much of hemodynamic data as to constriction. It's an echo business. Okay? Echo is the next step. Okay. This mode is most consistent with frequent ectopics, LVAT, tamponade, artifact, sinus arrest / pause. We have shown this last time. Tamponade, and this is what? The
This
M
is
mode
extreme
equivalent
of
exactly.
pulsus paradoxus.
Exactly. Pulsus paradoxus. See, the aortic valve tends to close during inspiration and it opens during expiration. So the flow is so scant as to keep the aortic valve closed or semi-closed in inspiration. Okay. Now, this upper invasive hemodynamics correspond to which echo? So what we are seeing up is what?
Pulsus paradoxus.
Pulsus paradoxus. Where is pulsus paradoxus here? A, B, C, or D?
C.
C.
B, sorry.
B.
C. Yeah, you see? During, this is the LVOT. During inspiration, it goes here. During expiration, it's here. So there is decrease during inspiration, more than 10%. What is this sign then? What is this?
This pulsus alternans.
Very good. This is the echo equivalent of pulsus alternans. Beat-to-beat variation in severe LV dysfunction. Great. Now, the structure marked by the red line is found in clinical studies to associate and correlate with risk and severity of coronary artery disease, diastolic dysfunction, visceral adiposity, all of the above, none of the above.
All of the above.
All of them.
Thank you so much. Thank you so much. I think we are done for this pericardial disease. Okay.